Emil and Zahra, we are online now, and we'll be starting in a few minutes. I think one of the panelists had her computer crash, so you wonder if these operating systems are not running planes and critical components, because if it happens at the wrong time, what the consequences will be. But Dr. Schaefer will be joining in a minute or two. So essentially, this is a session where the topic is that we'll be discussing using data to improve the delivery of healthcare. I'm excited to be here and excited to have worked with Mr. Khizer, and Mr. Ali Jan, who's the Secretary, Primary and Secondary Healthcare Department, Government of Punjab. It's a very large population that the department serves. I think by the numbers, Punjab is the 11th largest population in the world. So it's a lot of people to take care of and to provide improved healthcare delivery and services. And we will be discussing how we use the power of data to enable that. So I'm waiting for the organizers to give me a go ahead so I can make the initial introductions, and hopefully Dr. Schaefer will join in a second, but if she does not in the next 30 seconds, we'll just go ahead and start the proceedings, and she will join and we'll introduce her when she's online. Hope that's okay. So, Dr. Heather, if you can turn on your video, please, since you are a panelist. Appreciate that. Thank you. We will go on silence for maybe just 20 seconds while we wait for Dr. Schaefer to join. Okay, so I think in the interest of time, let's start, and hopefully by the time I have introduced Mr. Khizer and Mr. Heather, Dr. Schaefer from LUMS would have joined. So officially we are online now. Welcome to this session where we'll be discussing the use of data to improve the delivery of healthcare, very specifically taking the example of the province of Punjab. We have 1 hour for the session, and we'll leave 15 to 20 minutes at the end for participants to share their views and post questions. So please do keep writing your questions on paper or electronically. There will be an opportunity to ask them. For the roadmap of this session, we will cover 3 topics: how Primary and Secondary Health Department, Government of Punjab has been able to use data to lay the groundwork for effective healthcare program monitoring and delivery. We'll then talk about Clear PCA's work on helping the department to strengthen evidence generation for these key programs. We'll then pivot towards discussing how academia, government, and research organizations like SERP and Clear PCA can effectively work together, share data, and develop evidence and insights for better healthcare delivery to citizens. We'll conclude by discussing some models for data sharing and best practices to protect health data while making it available to relevant stakeholders. This is a lot to cover, so I request my fellow panelists to be brief in their comments so we can cover all of these topics and then leave Q&A for participants to engage in a meaningful conversation. First things first, let me briefly introduce our panelists. Mr. Khizer Afzal Chaudhry, Additional Secretary, Administration, Primary and Secondary Healthcare Department is with us. He's a career civil servant from Pakistan Administrative Services with varied experiences spanning over 15 years. That includes field work and desk assignments, including Deputy Commissioner in 3 districts of Punjab, an electrical engineer from UET Lahore who possesses a master's degree in urban management and development from Erasmus University, Rotterdam. I hope I pronounced that all right. That's in Netherlands. That makes 2 of us. electrical engineers on the panel. I myself am a double from UET Lahore. Great to have Mr. Khizr on the panel. Welcome. And while we wait for Dr. Shaper to join, let me introduce Heather Ali Khan. Dr. Heather is an expert in public health research and health data analytics with extensive experience in program management and global health initiatives. Dr. Shaper is here. Thank you for joining. Kindly enable your video. Great to have you, and I'll introduce you in a second. Back to Dr. Heather. Dr. Heather has previously collaborated with international donors, government agencies, and healthcare organizations to drive data-driven decision-making and improve health services. Previously, as a technical project manager with the primary and secondary healthcare department, he facilitated facility accreditations among 125 public sector facilities around Punjab based on compliance monitoring data. Dr. Heather holds a Master's of Bioethics and an MBBS from Aga Khan University, so he's a fully qualified physician. I'm glad to have Dr. Heather on the panel. Welcome. Dr. Shaper Mirza, thank you for joining. Dr. Shaper is an immunologist and molecular microbiologist. She is an associate professor at the Department of Biology, Lahore University of Management Sciences, also known as LUMS. Before joining LUMS, Dr. Mirza served as an assistant professor at the University of Texas Health Science Center. That's in Brownsville, and also was at Houston campus. Dr. Mirza was among the first 5 Fogarty Fellows from Pakistan. She was awarded the fellowship to work on sexually transmitted infections in Pakistan. She is currently an active member of American Society of Microbiology, American Diabetes Association, Pakistan Biological Safety Association, and Pakistan Infectious Disease Society. Welcome, Dr. Shaper, to the panel. So without further ado...
can you hear me?
Yes, we can hear you, Dr. Shaper. We can hear you totally fine. Yeah, thank you. Sure. So with the introductions out of the way, let me ask the first question. Let's dive in, and let me ask the first question to Mr. Khizr. That HISDU, under the leadership of Mr. Ali Jan, Secretary, Primary and Secondary Health Department, has invested resources and built capabilities to help the department with using data for better program delivery. Kindly, if you can elaborate a little bit about the role of HISDU and other mechanisms that are in place in achieving the goal of better program delivery to the citizens.
Thank you very much, sir, and good evening, everyone. Good afternoon, rather. I would try to be brief, although there's a lot to say about HISDU and what primary and secondary healthcare is doing. But let me go back to 2015 when our health department in Punjab was bifurcated into 2. Primary and secondary healthcare department was responsible for the BHU, rural health centers, tehsil headquarters, and district headquarter hospitals. In addition to that, we were also supposed to look after the vertical programs. And the other department was the medical education or the specialized healthcare. So in 2015, when we carved out this department out of health, HISDU, Health Information Service Delivery Unit, was created at Primary and Secondary Healthcare Department. And HISDU has since created various data collection portals and applications that actually precipitate into decision support systems in form of dashboards, etc. There are almost 50 applications and dashboards which are operational right now. And I believe that HISDU has made some good data which is readily available, and that moves away from garbage in and garbage out models. HISDU's network of data collection works from the ground up. So instead of approximations and estimations, there's a real-time data available. And with one single click right now, if we want to know that how many health professionals were available in our hospitals, so we will have a clear picture that how many were present, how many were supposed to present, and how many are absent, and what are the reasons of their absence. One of example which we are really proud of is EMR, electronic medical records. It's a patient level line lists are available with us, and that is used to analyze our needs. And then on those needs, we actually form our policy as well. It actually tells us that whether you need disease trends, medicine utilizations at district, SELO level, BHU level. In addition to that, HISDU has also added value when we speak of the vertical programs. There are 7 different vertical programs working in primary and secondary healthcare department, starting from the non-communicable diseases all the way to hepatitis control, TB and AIDS control, etc. And it has also embedded a culture of using data to identify the bottlenecks in the department. So thereby shifting from business as usual to the models of governance. Since we all know that Ali Jan Saab and the current government, they have an increased focus on overall health service delivery. And I believe that HISDU, by providing overall surveillance, track and trace of medicine, in addition to availability of HR, presence of HR, and most recently, a creation of a paperless environment in our department. So I believe that primary and secondary healthcare is kind of indebted to whatever HISDU has provided with all its IT support and data.
Okay, great. Thank you. And I think, in our work at SClear PCA, we have been working closely with the HISDU and internal delivery unit and other organs of, the other structure that Mr. Secretary Ali Jan has put together to effectively monitor and implement, program delivery. And and absolutely agree. This provides a very solid foundation to build on. And I must say, as we were talking earlier, that Punjab is the 11th largest population in the world. If it was a country, it would be 11th largest country in the world. So that's a lot of people to serve, and it's very heartening to see use of data for effective program implementation and monitoring. Having said that, if I may ask you, Mr. Khizr, if you would describe the role of IDU and how IDU ingests and takes this data from HISDU, plus other mechanisms that are in place that in turn help the leadership at primary and secondary healthcare department to effectively implement and monitor the programs.
Just like HISDU, IDU is another integral part of primary and secondary healthcare department, and HISDU and IDU, they work in unison and they are in close collaboration. And we actually refer to them as the performance management routines. There are certain performance management routines which we are very, serious about in primary and secondary healthcare department. We believe in sending out our messages, directions, and then we take a feedback of whatever is being conveyed to our field formation. And these routines are held in 3 main frequencies: monthly district level conferences with CEOs and MSs of district headquarter hospitals. Tehsil headquarter hospitals are also made part of that. We go for weekly check-ins with the field staff. And most importantly, we have a daily morning review meeting with the department and other stakeholders. And HISDU collects data, and IDU helps to assemble them into implementable knowledge products that identify district level performance on the various key indicators that the department tracks. I believe that IDU is an essential ingredient of our overall policy making. If we talk about the KPIs, they are crafted by the IDU in consultation with HISDU, which provides the data and the vision of the political government and the secretary of the department. Most important example whenever I speak of IDU and the achievements or the good work they have put in is the Lahore immunization campaign. Last year in 2023, unfortunately, Lahore was the lowest with respect to the routine immunization, or overall, what we call it, a fully immunized children. So our percentage of fully immunized children of Lahore was 69%, while Punjab stood at 87% or so. So with help of data which we collected from HISDU's portals and applications, IDU came up with a plan that we need to go for a dedicated campaign in order to improve the routine immunization. So they actually formulated the entire sketch of the plan. We used our polio workers who came up with the data that where are the missing children and in which ways we can go and reach out to them and administer routine vaccines to them. And you would be amazed to know that within a span of 6 months, now the routine immunization of Lahore stands at 85%, and Punjab stands at 91%. So this jump of more than 16% is it's evaluated by the third party. And one important thing to note in this effort, which I think Primary and Secondary Healthcare Department has carried out, that this percentage increase took months and years in other countries. For example, Bangladesh, this change took almost 3 years. In India, it took almost 2.5 years. While in Punjab, in Lahore, we managed to do it in less than 6 months. So I think the credit goes to IDU. And then again, accountability is one of the key factors in our department and maybe in overall administrative working of Punjab government. And the idea is to build a regime of accountability to push for improved performance. A set of input, output, and outcome indicators are tracked. For example, attendance of clinical staff that I have already mentioned, presence of doctors, availability of standard medicines in facilities. We have a list and we call it standard medicine, which are required in every facility. Actual medicines dispensed. And together, these help drive actual service delivery in hospitals. And again, the credit goes to IDU that it has also chalked out performance management routines, which help us provide impetus for providing or improving rather service delivery through identifying needs and addressing the shortcomings in our system.
That's great. Thank you, Mr. Khizar, for saliently describing how all this machinery of HISDU and IDU works together for effective program delivery and better health outcomes. With that, I'm going to shift to Dr. Haider. I know, Dr. Haider, under the CLEAR PCA, you did a very elaborate overview rather, or dug into how the data flows across various parts of the organization being primary and secondary health care department. I know that's there are a lot of systems, there are complex data flows, but if you strictly in 4 minutes can explain, I know you have something to share also, and feel free to project what you need to project, but if you can please dive in and help us sort of navigate how all of this is put together. So go for it, Dr. Haider.
Of course, Imran, very grateful for the opportunity to speak about the work that we did. So our work kind of centered around assessing how Punjab is collecting data, and we used the hepatitis control program as a test case to illustrate this. Pardon me. So to start off with, one thing I'd like to flag is that Pakistan, particularly for healthcare, has a decentralized model wherein the provinces are responsible for health as a subject. So for the hepatitis control program, Punjab operates about 236 healthcare facilities. These include primary and secondary healthcare facilities, teaching hospitals, and autonomous medical institutions, the latter two of which are controlled by a different department, which is the specialized healthcare and medical education department. The primary and secondary healthcare facilities, which include your district headquarter hospitals and those below that, these provide regular reports to the district health office. This may be through aggregation of paper-based records, as well as electronic data that is entered into an electronic medical record-keeping system. I believe this was an initiative that had its groundworks around 2016 and was fully launched around 2020. So the hepatitis control program gets the data both from the electronic medical record keeping system as well as stock data that is collected through Google Forms. These pass upwards to the secretary through the internal delivery unit, or IDU as we've been talking about, or the secretary's monitoring unit, and then that contributes to decision making. Now, to speak about the electronic medical record system, this is part of the health management information system. So to start off with, the patient undergoes registration. They are allocated a medical record number against their computerized national identification card, or CNIC. At the time of registration, the patient's address and telephone number, all of these details are noted. And as they go to the clinic, they are screened through a rapid diagnostic test. If they screen negative, they are vaccinated for hepatitis B, and the EMR system, electronic medical record system, allocates a follow-up date as to when they should come for their next dose of vaccination. If the patient fails to come for their subsequent vaccination doses, a call center that is located in HISDU then makes a phone call to ask them, why, when can they come, so on and so forth. However, if they screen positive for either disease, they undergo a PCR testing, which assesses whether or not there is the virus present within their body. The EMR system prints out a barcode, which is stuck onto the serum separator tube, and this is dispatched to the central laboratory for testing. If it's not detected, that is the end of the matter. It's saved and closed. But if it is detected, they go through baseline and testing and treatment. As part of the EMR dashboard, whatever medication is being dispensed is allocated to them. In Punjab, medication is free for the patients. After being enrolled for about a year within the system, they undergo another PCR test, which assesses whether or not the sustained virological response is there, which basically means is the virus no longer detected in their body. If it is, if the virus is no longer detected, the patients are issued a certificate of cure. If it is not, then they're referred to a tertiary healthcare hospital. All of this data is aggregated in a dashboard that is maintained by HISDU for the hepatitis control program. As Mr. Khizer was highlighting, HISDU maintains over 50 dashboards, and all of these dashboards are kind of tailor-made for each of the vertical healthcare programs. This can be assessed on a map. So if you click on any of the districts in the map, it highlights that district specific statistic. So this is the data flow that we highlighted. If there's time, particularly in the question and answer session, we can highlight some of the challenges that are within this. Thank you, Imran.
Thank you very much, Heather, for describing this great work that you did with support from the CLEAR PCA, which is hosted at SERP, and this is a great foundation to understand how the data flows, and hopefully we'll be doing some subsequent work. There's a lot of good work that happened in the last 1 year, but there's more work to be done, and we'll talk more about it. But thank you for highlighting that. So let me switch back to Mr. Khizer, and I think you have been working with the polio eradication campaign. We would be interested in hearing your insights regarding how you keep track of progress of polio initiative, how the data is collected, and the impact of vaccination campaign decisions.
Yes, as we were discussing before the start of this session, that Pakistan and Afghanistan, unfortunately, are the only two countries in the world where polio virus is still present. And Pakistan, over the years, has no doubt done a lot of work in order to eradicate polio. But somehow we are still having positive polio cases. We have positive environmental samples. So the situation overall needs a lot of work, which is to be done. As far as how we track and how we carry out polio campaigns with the help of data and IT interventions. So we all know that our polio workers, they go door to door and administer polio drops. So they carry along themselves our tally sheet. We call it a tally sheet, which actually is a document on which we keep a record of how many children they had administered polio drops to, how many children were not available, and there are certain other information. For example, if they find out that there's a child less than 5 years of age who has not taken any vaccination, which was mandatory, so they also record all that sort of information in the tally sheet. But moving further, when the data goes to the area in charge, the UCMOs, it is then converted into electronic data, and we have a portal which we call as IDIMS. So the information is shifted to our portal. And in addition to that, we also have a portal which is called SES, which is also maintained by HISDO, just like IDIMS, where we enter the information of all those children which were missed or which were zero-dose children, meaning thereby who had not taken any or missed, or they had missed any immunization other than polio. So once we get the information, then we start to track and trace the children who had been missed by either our vaccinators or by the polio workers. So this information is shared with the districts. This information is shared with the national EOC and the Ministry of National Health. And at times, dedicated campaigns are conducted just to cover those children who have been found missed during our campaign, and the data is available with us. We carry out health camps, we go for exclusive campaigns, and at times, which, as I have already mentioned about the Lahore campaign, we carry out dedicated campaigns of routine immunization, and we have done it in 11 districts. So the bottom line is that the data which are the last year of our polio eradication initiative collects, that is translated into a data which is readily available in electronic form. And with the help of that data, we track, we go to those children, and we cover all those children which have been missed. One important aspect of our track and trace system, which we do through our application, has helped Punjab reach out to more than 400,000 children which were initially missed by our vaccinators or polio workers. As a result, now Punjab only has 2.3% of still missed children out of 23.3 million less than 5 years of children, which is way less than other provinces of Pakistan. So polio program is not only using the applications and the IT interventions, but the data which we collect, we are so dependent on that if in case our teams miss out on translating the data into electronic form, there's a huge gap, and it takes then months and months to plug the gap, which actually takes place whenever there is a loophole in shifting the data from the paper to the electronic form.
Wow, those are impressive numbers. Just 2.3% children which are not covered for a population which is the 11th largest in the world. I mean, those are impressive numbers indeed. So, Mr. Khizr, let me ask you this question. I think you briefly mentioned about the integrated health week camps that the department holds. Some of the analysis that the Clear PCA team working with IDU has done, how do you think that's helpful in further using this data for the benefit of the department?
I believe, as I was discussing again before the start of the session, that the most important thing to me, maybe it's not the data, but the quality of data. So at times we have a huge chunk of data, but it's not always very beneficial. So by the help of IDU and HISDO and your organization, the data which we collect is of highest quality. And I believe that with the help of that data, now we have a targeted information. Now we know that where our interventions are required, where are the loopholes, and what methodology will be the most beneficial in order to plug them. As far as our health week camps are concerned, I tell you now we have such informed information that our medicine, as we all know, that our medicine is stored in our mass collection depots. So what we do is that through that information which we collect through our integrated health camps, we know that there is some XYZ Union Council where there are the largest number of hepatitis patients. So we roll out our medicine accordingly. Likewise, we have started making or drafting rather our policy on basis of demographic and geographic details. There are certain districts in Punjab. Few years ago, we had no idea that the disease prevalence in those districts, when we speak of hepatitis and AIDS, that was so big, so large, but we had no idea. But with the help of these health camps, when we underwent screening of the residents of those areas, we found out that there are certain areas which are disease pockets. And not only we started providing medicine to the patients of those areas, we also improved our ingress of vertical programs. Not only we mobilized our community, we started engaging the community, and as a result, the overall prevention system was kind of rolled out to those districts. And I believe that all this information that was gathered through integrated health week camps, that has been very beneficial. Now, if we link it to our polio eradication initiative, I have always emphasized that if Punjab has to become a polio-free province, although we are for last 3 years or so, but in the long term, if we want to stay polio-free, we need to engage and we need to reach out to our high-risk mobile population, which at times we also call the priority population, which comes into Punjab from KP or Karachi or Afghanistan. So what these health camps has done to us is that we now know that where are the pockets of our HRMP, because these are the populations which keeps on coming and leaving Punjab, and they are not the permanent residents. But when we held these integrated health camps, through screening and through those patients who actually visited our health camps, we got an information and we incorporated that information into our micro plans. And micro plan to us is the most sacred document whenever we go into a polio eradication campaign. So in brief, if I rate integrated health week camps as one of the main source of information with respect to not only the disease pockets, but other than that, with respect to high-risk mobile population and what sort of vertical program intervention we need in certain area, that was also kind of, actually apprised with the help of the data collected through integrated health week camps.
Thank you, Mr. Khizar, for elaborating on that question. So Dr. Shaper, you have been also helping us make sense of this data that primary and secondary healthcare department has very kindly shared with us on integrated health weeks. And I think one of the concerns that we had noted earlier was that maybe there's an overrepresentation of patients. So in terms of predicting disease incidence, it might not be more reliable because you are oversampling because of the fact that only the patients with the disease will be showing up at these camps. So how do we address that concern? And is that data still useful in further probing disease patterns in the system or in a geographic region? If you could kindly address that concern.
Yeah, I think that's kind of an interesting question, and we have talked about it multiple times. First of all, thank you so much for having me here. And secondly, I would like to congratulate the Department of Primary and Secondary Health for their efforts in improving health of the district and of the province at large. So to address this question, I think what we can do, and I think Khizar Saab had already alluded to parts of it, that we can take areas where there is a projected
Can 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 people mute? Can people not speaking mute themselves, please? Because we are hearing background noises. Over to you, Dr. Schaefer. Thank you.
Yeah, so I think that we can identify areas where there are projected high levels of disease and then maybe go back into those areas and do some granular studies. And among those granular studies, we can actually look for the actual number of individuals who are diseased, because most of the time when these camps are set, people who are attracted to these camps are people who already have a problem. So that might give you or kind of give you a misrepresentation of different geographic areas. But then taking those numbers as your preliminary findings, you can go back and then probe those areas further into looking at the original prevalence of that disease. And once you have the data, then you can definitely deploy more targeted interventions in those areas, which could be identifications of actual number of individuals who are suffering from the disease. And then, of course, you can go more into the behavioral, socio-demographic, and other kind of information, so that whenever you have interventions, those could be targeted interventions and they could be culturally sensitive interventions, so that they can be taken up more efficiently in those areas. Now, in doing that, there are other stakeholders or there are other institutions that will be more than helpful in facilitating the primary and secondary health in achieving these goals. And these could be academic institutions. I mean, LUMS is already facilitating studies with SERP, and LUMS can join hands with primary and secondary health also, and we can deploy our teams into those areas to estimate the actual prevalence of disease. I think having those numbers is really important in order to predict what's going to happen in the next 10 years, in order to also project the amount of money that will be deployed or that will be utilized, or the economic cost of disease in those particular areas. And then you can also calculate the numbers that if you reduce the burden of infection or reduce the burden of non-communicable diseases in those areas, how your numbers are going to reduce. So I think that will be a very critical piece of information that can be utilized by the department in order for them to allocate resources or appropriate resources in appropriate areas.
Thank you, Dr. Schaefer. And as you were discussing this, and responding to my last question, something that popped in my mind, and that was that perhaps we should discuss how data can be more effectively shared between the government, academia, and research organizations like CLEAR, PCA, and SERP. So putting this question out to you, how can this work, and what would be the outcome of such collaboration?
Yeah, I think there are two things. One of the things I think Khizr Saab had already mentioned, which is data monitoring. So all that data that is coming in needs to be monitored in order to ensure the data quality. And the second thing is data safety and security. So we can have like a data safety and security board in place where people will monitor the safety and security. There can be certain audits in place which are going to ensure that data is only accessed on request, and then when somebody requests that data, there are further audits to ensure that the patient privacy and patient confidentiality is maintained when that piece of data or that piece of information is being shared. Then data storage. So storage can be on devices that are encrypted, password protected, and then you should have very limited access to those devices. Along with that, accessibility can also be monitored and audited over a period of time to ensure that it is only being accessed to people who have been granted access previously.
But let me probe this further, because I think, taking this position from the vantage point of Mr. Khizr or the leadership at Allianz level, the Secretary Primary and Secondary Healthcare Department, I mean, they could raise this a query that look, there are very weak data protection regimes in Pakistan. There is no law around data protection. So having said that, would the mechanism that you described, you think that would still function? Is that something that's practiced in other countries? If you could address that concern, because that could certainly play a role in terms of organizations being willing to work with others, and so that the data is available to all the relevant stakeholders and can be analyzed for insights for further inquiry.
Yeah, so in most of the countries, like in United States, National Institute of Health has specific plans for data monitoring and data safety. They have data safety and data monitoring boards in place, and those boards actually do the same thing. And then those boards, underneath those boards are the ethical committees, and those ethical committees ensure that most of the data that is shared with other individuals for data analysis or for other purposes, it is all ethically coded, and without coding, none of the data is shared. So most of the patient identifiers are coded so that they are not, so people who are accessing that piece of information, they don't have patient identifiers. And most of the sensitive information like CNICs, like their names, their cell phone numbers, their place of residence, all of those information is coded. And that's the responsibility of the Data Monitoring and Safety Board, to code all of that information and just give you numbers or cumulative numbers if you want to do analysis. Because data sharing is really important. I mean, because I've just mentioned several things which are really important. For example, antimicrobial usage. So they have information on antimicrobial usage, but unfortunately we lack information on numbers of antimicrobial resistant infections. And if that information is available, one, it is a sensitive information. Two, it needs to be analyzed in order to establish the prevalence of resistant infection. So I think having a strong data safety and monitoring board in place, which works along with the either National Bioethics Committee or the institutional review boards, will provide the strong security that we need for data sharing.
So I gather what you're really saying is that even in the absence of a national level, data protection regime, there are still models available out there.
Level, yes.
That at institutional levels can be used as a framework for implementation in Pakistan and address some of the concerns that will be addressed by a national law, but you could bring it down to the institutional level and make arrangements between institutions to make it happen. No, thank you for. I mean, that's great insight. But let me ask you a little bit further. Maybe we can use your work on antimicrobial resistance. I mean, you refer to that. So, for the benefit of the audience here, would you like to describe what that is for, and why that's an important area to focus on in the context of Pakistan?
Absolutely. I mean, there is like an epidemic of antimicrobial resistance all over the world. And World Health Organization had identified different organisms and have also presented with the level of threat that each one of those organisms present. Now, having HIS2 in place, I think HIS2 can serve as a hub and collect information from all hospitals. At the moment, National Institute of Health in Pakistan have a national action plan on antimicrobial resistance. They also have about 43 different centennial sites. But unfortunately, there is no place, no forum, no platform where all of this information is available for people to analyze it and to figure out the trends in antimicrobial resistance in Pakistan, the organisms that are mostly involved in antimicrobial resistance, and above all, the number of deaths that are attributable to antimicrobial resistant infections. I mean, this is really important to establish the importance of it. And if HIS2 can start accumulating or collecting all of that data from hospitals, because each hospital is working independently and there is a lot of information, but it is all fragmented information. If you can, in order to devise a policy, you need to put all of that information together, and then you can probably share it with the Punjab Health Commission. when it comes to hospital-acquired infections, because hospital-acquired infection also kill a lot of people. So Punjab Health Commission, they have already commissioned infection prevention control committees in each hospital, but now having this information, they might be able to refine the guidelines, the standards, and maybe give more recommendations to the committees, more strength to the committees, more power to the committees to actually go deeper into figuring out the hotspots within the hospitals that are responsible for antimicrobial resistant infections. And for antimicrobials, the pipeline is really dry. And we don't expect to see a new antibiotic coming up in the next 10 years. So we will have to smartly use the antibiotics that we currently have. And in a lot of cases, people are also repurposing these antimicrobials. But like I said, the data is so fragmented. And if HIS2 can somehow use their power to collect and collate all of that information and add a few more variables to it, we might have a very good system which we can use to identify the trends in antimicrobial resistance, organisms that are on the priority list of antimicrobial resistance, the bug-drug combinations, and then, of course, deaths attributable to antimicrobial resistant infections.
No, thank you so much for elaborating that, Dr. Shaker. So, Mr. Khizr, not to put you on the spot, but that's a big wish list in terms of sharing of data and collaboration and multiple organizations, including research organizations like SERP and Clear PCA, academic institutions like LUMS, and people like Dr. Shaper who are placed there, and the government of Punjab through their data that they accumulate in primary and secondary healthcare department and elsewhere. How can these organizations work together more effectively? What's your view of that?
First of all, let me agree in total to whatever Ms. Mirza said, because to be honest, I am a strong supporter and advocate of data integration, because we cannot work in silos. And if an organization has a lot of data, but that is not integrated with all other stakeholders, maybe the overall usage of that data is compromised. Having said that Madam raised, I mean, there were many good points which actually need our attention, and they can be of great help to us if we kind of achieve an integrated data information system, maybe led by HIS2 or some other department. But the only problem right now to me is that these decisions are policy decisions which actually are carried out by the government. And there's no harm in actually presenting our case to the government that we need a data integration hub. Maybe it can be done at the level of HIS2 or maybe some other department. PITB maybe can take a lead. But whosoever is going to do it, the overall benefits and maybe the outcomes, which for sure will be positive, there's no doubt about that. So an important takeaway from this session, to me at least, is that the points raised by Madam, especially with respect to the antimicrobial resistant infections, and to since I'm not a practicing doctor and I don't have enough knowledge of medicine as well, but this is something which I know from my personal experience, that maybe few years ago, an antibiotic which used to help me or my family is no more effective. So we are maybe going for more powerful antibiotics over the years now. So, but the point is well taken. And having said that, there's just a policy decision. Maybe the government might like to take a lead on that. But I think if government decides to go for it, it will have it will not be beneficial for overall 130 million people of Punjab, but it will also be fruitful with respect to their political mileage as well, that they came up with such an integrated system which is beneficial not only currently, but maybe after years to come, it will pay dividends. So yes, for sure, I'll discuss this with our Secretary Saab, and maybe in coming days, we will float a case for an integrated hub of such data.
I mean, that's Mr. Khizr, that's a great outcome. If nothing else, I mean, that's that's very welcome to hear. And believe me, we will take you up on that. And Dr. Shaper and the Clear PCA team will definitely be following up with you on that. But it's great and refreshing to hear that from you. So thank you, Mr. Khizr, Dr. Shaper, and I think we should probably jump into question and answer, since I promised we'll leave some time there, and I think we are right at 10 minutes to the hour. So let me try to combine some questions that have been received. I think we have 6 questions. Some of them are very long, but let me see what, prioritize that. And pardon if I don't ask you a question, but I'll try to go through all of them. So one question is about data, and that is that what are the challenges faced in directly entering data on an electronic medium rather than duplication of efforts and entering it on a paper and then transferring it over to an electronic format. And I think there's a related question also that Mr. Khizr mentioned data quality can often be a challenge, and that's related to this of maybe perhaps double entry. How does Hizru and IDU address data quality issues so that the higher data quality is ensured? So maybe Mr. Khizr, if you could address that question.
Sir, it's a very pertinent question, and I believe that yes, whenever we roll out a program, especially whenever it's a policy or IT intervention, there are always certain challenges. As far as our department is concerned, the biggest challenge when we speak of data is that there are certain areas, because our BHUs are situated in the areas which are at times riverine. There are bordering districts, and there are certain areas in Cholistan and other parts of Punjab where we don't have internet. So this is the first and the most important challenge which we face, that there are certain areas where we don't have the internet access. So what we do is that we make offline entries, and whenever we get an access of internet, the data is shifted to our portals. So at times that is not only time consuming, there are certain gaps as well, which at times, we cannot help it, but we try our level best to manage that. Secondly, our data entries are based on identification of individuals. For instance, if a patient comes to our hospitals and whatever record we are entering, we need information by information we mean a CNIC. In our rural areas, there's a trend that mostly our women are not registered with the NADRA, and they don't have a CNIC. So the people without a valid CNIC, if they become a part of our system, we cannot track them because we don't have a valid address, we don't have a valid phone number, etc. So this is another challenge. Another challenge, in addition to these two, is the people, the knowledge or the expertise of the people who are entering this data. Mostly in our hospitals, we have data entry operators and we have our IT officers, but that is not 100% in all across Punjab. There are certain hospitals in which our data entry operators are not skilled. And especially, usually we have 1 or 2 data entry operators, and if they are not available because of leave or any other issue, there is some person who's a layman who's sitting on a computer and making an entry. So there are likelihoods that the entry is not correct. So these are the certain challenges. And if you allow me, I have gone through the question. One question related to that was the overall quality of data and how we ensure that the data is, not reached out by the people who are not concerned. So for that, since I am not a technical person, but I know from my experience that our data is encrypted and they have 3 level encryptions of our data. So there is no likelihood of our data being breached. And since 2015, there has not been a single incident in which our data was, hacked or breached or something. As far as the data quality is concerned, the data which we receive in our portals is complemented by people who are working there as our HR managers. For instance, if we speak of our attendance, so the biometric attendance, we not only get the biometric attendance results in our portal, we also get the attendance which they mark on the register. So there are ways to complement the data which is being sent on our portals. And another extension of this question was that do we have doctor per BHU and doctor per RHC information? Yes, we have. We have 200, and though I'm not going into figures, but just to be, just to clarify that out of 2,500 BHUs as we speak, there are 349 BHUs which do not have doctors. We have the information that how many RHCs are there which have at least one medical officer. So the information is readily available, and if somebody wants it, we can provide it just with one click. And as far as it's being publicly available is concerned, no, not all of our information is publicly available. Our portal has all the orders, all the proceedings with respect to inquiries. That data is available. The orders we issue all day long, and all the orders since 2015 December, they are available on our portal. But as far as the personal information of our HR staff, the EMR data or alike data, that is not available on for the public. But if somebody comes to us and requests for some certain data, we just scrutinize the application and we provide. If the person is relevant and the data he or she is asking is, cannot be used in any wrongdoing of any sorts. So I hope I have tried to answer all the questions. If there's supplementary questions, I'm available.
Thank you, Mr. Khizr. That's great. So, Dr. Schaper, let me ask you this question. I don't know if this is part of your expertise, but anyways, let's see if we can explore this. How important is incorporating climate change data and its effect on health indicators in Punjab, and how should we deal with the intersectionality of health and climate change?
I think it's a very important concern, and climate change is really having a huge impact on health. Now I'm going to start. So climate change doesn't only mean increase in temperatures, but it also means variability in the amount of rain that we get, the flooding, all sorts of things are included in climate change. And starting from maternal neonatal health and pregnancy outcomes, you see there are lots of papers that are published that are showing that because of the increasing temperatures, we are seeing a lot more preterm births, we are seeing miscarriages, and in Pakistan, we don't have any such data. Okay, there has been an increase in miscarriages and in preterm births because of the climate change. This is one aspect. Then there are lots of papers on neonatal outcomes also because of climate change. And then, of course, when it comes to infectious diseases, we are already seeing a huge endemicity of dengue. And then other mosquito-borne diseases. So I think that climate change somehow should be integrated into these health systems. And first of all, maybe a pilot, the government should run a pilot just to see how things have changed in the last 10 years. Because in the last 10 years, Lahore, not just Punjab, but the whole country had seen lots of variability in climate. I mean, if you remember the flooding of Sindh and then the outbreak of Salmonella infection, there was a huge outbreak of Salmonella infection post-flooding in the province of Sindh. So I think that those things should be considered in the next policies in order to improve on health outcomes.
No, thank you, Dr. Schaper, for that. I think there were, if I get the data wrong, I think there were close to 80,000 births that happened during the last, great flood in Sindh. So obviously that should be of concern, and to the policymakers, to the government, and everybody else, people here. So I think we are 1 minute away, but I also want to ask Dr. Heather. I think this is a long question, but very quickly, Dr. Heather, if you want to address your experience under the PRISM evaluation that you did in terms of studying the systems at primary and secondary health department, and specifically what are the parallel data flows and data programs? What are challenges in smooth operation of the data flowing between these different systems? So if you can address that very quickly in the last 1 minute we have.
Sure, Imran. Thank you for the insightful question. It's a challenging question because by kind of emphasizing some of the difficulties, perhaps we're also kind of taking away from the monumental effort in terms of implementing a digital system across such a populous province with a very wide variety of contexts and health institutions. But speaking of the challenges broadly, they can be summarized in three different domains. There are technical domains, for instance, are the indicators that are present within the dashboard necessarily relevant? Are they capturing the best set of information that's possible? So for instance, while Pakistan recognizes the third gender as an identity for national ID cards, your data systems record gender in a binary. So are the indicators accurate? That's number one. Number two, as I'd highlighted earlier, organizational challenges can include multiple reporting lines. Who is it that is receiving the data? What kind of decisions are being made based on it? And number three is behavioral. Are staff necessarily well trained on it? As part of their induction or when they're joining a clinic, are they receiving training on the accurate entry into the EMR system? Then comes aspects relating to provider-patient care. And for instance, if your doctor is staring at a computer screen, do you feel like you were well served? So there are multiple challenges that I guess over time and through the findings of our study, we can hopefully address them over the years. But it's a monumental effort in gaining data. Hopefully we can see how we can help it kind of frame monitoring and evaluation challenges better. I hope that addresses the question. If there are any follow-ups, please do let me know.
Yeah, and I think thank you, Heather, for that. And I think to the audience, one thing I would mention is that please do follow us on LinkedIn and other social media channels that we have. We will be developing one-pagers and summary of our work, and some of it will be more detailed, and it will be available on CERC's website as well as Clear PCA's communication on social media channels. So some of the questions that you have posed here, we will hopefully would have some response to them incorporated in some of the communication that will go out for the joint effort that we did with primary and secondary healthcare department, Clear PCA, CERC, and also involving experts like Dr. Shaper in all that analysis. I think I'm allowed 2 more minutes. We are supposed to go 5 more minutes. 3 are consumed. So maybe last question, and I'll read the question. It's a little cryptic, but how can communication, non-communicable disease prevention, health awareness be incorporated using the data insights available at HISRU? So I guess maybe Mr. Khizer, I'll pose that to you, that in terms of insights that we develop, is there a possibility of communicating that to, at mass scale for citizen awareness? Over to you.
Yeah, I'll just quickly give one example. We all watch TV, and we might have seen that on TV we come across these polio awareness advertisements, and we might have seen that these polio awareness advertisements are only Pashtun centric, and usually the actors who appear in those advertisements are speaking in Pashto accent, and the setting of the advertisement is also Pashtun. So that information is data driven. We know that most of the people who refuse polio drops to their children, they are either living in the Pashtun speaking belt or they come from Pashto speaking backgrounds. So in order to address, since now from the information which we collect through data, now we know that these are the people who are to be targeted. As a result, we've come up with the dedicated advertisements or media campaigns which address not only the myths which are prevalent in that area, but we also try to convey that what can be the repercussions if their children are not administered polio drops. So the point here, which I'm trying to make, is that whatever information we collect through our portals and apps, that is translated into a policy-driven, what we can say that policy-driven mechanisms. So polio is one such example. Recently, we had this report from WHO that the diabetes prevalence in Pakistan is highest in the world. So the information was gathered from our, the thing which I already mentioned, that the health weeks, the health camps which we established, and the clinics, NCD or CDC clinics which are operational in our hospital. So now we got the information. After getting the information, we found out that these are the certain pockets where there's the highest number of disease prevalence. We went there, not only engaged community, but we also used the social platforms and the print and electronic media to have the ingress and to reach out to the people who were initially not even, not even aware of the fact that they were suffering from the disease. So our vertical programs, they are information driven, and the information is the one which we collect through our portals, which are being operated by HISTO.
Thank you, Mr. Khizr. You had the last comment. We are over time. Please do engage with us on LinkedIn. I think Nakil posted a link in the chat session. Please follow us. We'll have very useful information for our continued work with CLEAR PCA and primary and secondary healthcare department. And it's great to have such leadership as Mr. Alijan and Mr. Khizr Chaudhry at primary and secondary healthcare department, and using data for better healthcare delivery in one of the largest populations in the world, 11th according to the last estimate that I had. Thank you, Dr. Shaper, for contributing to this session, and had really an above